Hey doctors, welcome back to Jab Studies Made Fun for Anesthesia Part 4. In this part, we're going to talk about pharmacology related to the anesthesia topic. We're going to have this topic done in 2 videos. Alright, so for the first video guys, let us know about what are the drugs and what are the, if you see the type of drugs which are used in anesthesia with respect to the pharmacological aspects. First we need to know there are muscle relaxants, then you'll have IV inducing agents, inhalation inducing agents and local anesthetics. For this today's video, we're going to talk about muscle relaxants and IV inhalation agents. So before I start about muscle relaxants per se, let us talk about what happens basically in our neuromuscular junction. Basically guys, whenever you see, first you will have the impulse, okay? Whenever the impulse first comes, this impulse will activate the calcium channel, due to which this calcium channel sends a signal and the acetylcholine receptor, the acetylcholine which is present here in the synaptic vesicles will be pushed at the level of the presynaptic cleft. From here it comes out and goes to the receptors which are present in the postsynaptic cleft. Now the acetylcholine receptor which is present in the postsynaptic cleft is actually a pentameric structure in which you will have alpha, 2 alphas, beta, gamma and delta. And this acetylcholine is going to go and bind to 2 alphas. Okay, I'll repeat one more time. Whenever you'll have an impulse, this impulse will then activate the calcium channel and this calcium channel will push the acetylcholine which is within the pouch into the cleft over here, and from the cleft it goes and binds to the receptors in the postsynaptic area. In the postsynaptic area, the acetylcholine receptor are pentameric in nature, in which you will have alpha, beta, gamma and delta, in which there are 2 alphas. At these 2 alphas, your acetylcholine receptors are going to bind. Once these acetylcholine receptors are going to bind, from there sodium is going to get released. From the postsynaptic membrane, sodium gets released in a high number. And you all know sodium is responsible for depolarization. Okay? So whenever there is depolarization, what will happen? There will be contraction. This is a basic layout of neuromuscular junction. Okay? Once more, impulse, calcium pushes the acetylcholine to the presynaptic area. From there, acetylcholine goes to the cleft, and from there it goes and binds to the receptors present in the postsynaptic membrane. The receptors are pentameric in nature, goes and binds to 2 alpha molecules. Once it goes there, sodium gets released. Sodium causes depolarization and depolarization causes contraction. So this is everything which is in the neuromuscular junction. If you did not understand the explanation, here is a stepwise pointer with respect to whatever I just now told. Okay, moving on guys, let us talk about the types of muscular relaxants. You need to know there are 2 types. One is depolarizing, which causes an action, and other one is non-depolarizing. The only example which you need to remember in depolarizing is succinylcholine, which is also known as succinylmethonium. Okay, they are short acting. They're used in times of difficult intubations, in case of emergency or rapid sequence intubation, which we talked earlier. Now let's talk about some detail in non-depolarizing. In non-depolarizing, you need to know you can divide them amongst, first of all, based on the structure. If the structure is steroidal, or if the structure is benzyl isoquinolones. So what you have to remember here is only remember the steroidal types, then rest will be benzyl isoquinolones. Remember the steroid by the mnemonic of PVPR: pancuronium, vercuronium, pipecuronium and rocuronium. So these are the steroidal non-depolarizing muscular relaxant. Next, the other rest are going to be benzyl isoquinolones. So this is non-depolarizing muscular relaxant. First PYQ done. Then based on the duration, you can further divide non-depolarizing muscular relaxants into long-acting, intermediate-acting and short-acting. In this you have to remember, in long-acting, the longest acting is our doxacronium. Remember, doxacronium, doctors are going to work for long hours, 72 hours like this. So remember, long-acting, non-depolarizing, if they'll ask you, that's going to be doxacronium. If they'll ask you short-acting, one remember, short-acting is going to be mevacronium. But if they'll ask you what is the ultra-short-acting, remember that one intern who never used to come in the duty, Ganta mein koi kaam karunga. So remember that way, gantacronium is going to be an ultra short acting. Okay, ultra short acting, gantacronium, and longest acting is going to be doxacronium. Okay. Next over here guys, let us talk about depolarizing muscular relaxant. In depolarizing muscular relaxant, which we were talking about was succinylcholine. How does it cause muscular relaxant? First, we already talked about how a normal pathophysiology works. So remember, from there the signal comes, acetylcholine receptor binds, sodium is released and causes depolarization. Something similar happens with respect to succinylcholine. Remember guys, succinylcholine is equal to 2 molecules of acetylcholine. One PYQ here. Okay, succinylcholine is equal to 2 molecules of acetylcholine. What this succinylcholine does is, it goes and binds to this pentameric receptor. It goes and binds to this pentameric receptor, and it's basically mimicking its action. Now normally, whenever one acetylcholine is going to go and activate, there will be, for example, 1 sodium coming out. But as I told you, succinylcholine is double of that of normal acetylcholine. So if one succinylcholine goes and activates, it's going to release lot of sodium. So that is why, which normal the basic function was contraction. Now you will have fasciculations. What is fasciculations? Multiple contractions at the same time. Okay. Now how does this stop? Basically what happens is, once the sodium action is done, you need to know sodium gets its action okay. Sodium moves through Sodium moves through 2 channels. One is going to be your voltage gated, and one other one is going to be your time gated. The voltage gated is going to be open, but the time gated is only open up to 30 seconds. So once after this 30 seconds, the sodium channels it's closed. No more ions are going to transport, and if there is no more ion, there will be no more depolarization. If there is no more depolarization, there will be no more contraction. So that is how succinylcholine is going to give you the action of muscular relaxant. And how is this reversed? The reversal is done by a drug, by an enzyme which is pseudocholine esterase. Pseudocholine esterase is stored in the liver, and it is transported to the neuromuscular junction with the help of the plasma. So this is all what you need to know. Succinylcholine is equal to 2 acetylcholine. It goes and binds. Now the sodium first, there is a lot of amount of ions which are released, causing fasciculations. But after a while, in 30 seconds, the time gated channel are going to get closed, due to which the ions within them are not going to depolarize anything. Thereby there will be no contraction, and there will be muscle relaxant. This action is reversed by an enzyme called pseudocholine esterase present in the liver, and it is transported with the help of plasma. If you did not understand the physiology, I have written over here, and you can check it out. Everything, whatever I just said, is written over here. Okay. So if you talk about the basic things which we just now discussed, first of all, remember what is the dosage for succinylcholine. The dosage is going to be around 1 to 2 milligram per kilogram. How long duration is going to be? Duration is only going to be for 10 minutes. Okay. And how fast is the onset of action? Remember, time gated channels, that is for 30 seconds. So the onset is also going to be within 30 seconds. What is it? An agent of choice. It is an agent of choice in case of any emergency intubation, in case of rapid sequence intubation or difficult intubation. So rapid sequence intubation, difficult intubation, these are the modes where this is an agent of choice. And how is the mechanism of action? It is a non-competitive inhibitor because it just mimics acetylcholine. It is equal to 2 acetylcholine molecules, correct? And the reversal is done by pseudocholine esterase, which is produced in the liver and travels via plasma, correct? Now, what are the systemic side effects? Okay, first of all, remember it causes bradyarrhythmia because all the acetylcholinergic effects are going happening. So it is going to cause bradyarrhythmia. Heart rate is going to fall. That is why whenever before giving succinylcholine, you know the heart rate is going to fall. So give some drugs like atropine or glycopyrrolate so that it can help to increase the heart rate. Second thing is, succinylcholine is not given in case of any intraocular surgeries, because what happens is it causes sustained extraocular muscular contraction. Now usually what happens is, now succinylcholine causes fasciculation, but after fasciculation the muscle begins to relax. But because how our extraocular muscles are wired, there will be sustained contraction, due to which you will have a raised intraocular pressure, and this will further damage our eye if there is any case of eye trauma or if there is any case of raised intraocular pressure. So remember, succinylcholine is contraindicated in anything related to the global eye or something. Then, because of the fasciculations after the operation, patient will complain of post-operative myalgia. Succinylcholine causes contraction in the intragastric area, causing increase in intragastric pressure. Thereby, there are chances of aspiration. Okay, so remember what are the contraindications of succinylcholine. Now you know succinylcholine is basically causing contraction of the muscle, and because of contraction of the muscle, you know the potassium level is going to increase. So any condition which has hyperkalemia as its side effect or condition, you will not use succinylcholine. Instead of succinylcholine, you can use drugs like rocuronium. Okay, so what are the contraindications? Obviously hyperthermia. Remember, all inhalational agents and succinylcholine can precipitate malignant hyperthermia. All the other causes of hyperkalemia like neuromuscular disorders will be there. If you have pre-existing hyperkalemia already, any burn patient who's less than 6 months, if you will have a closed head injury or an open globe injury, why? Because it raises the intraocular pressure, sepsis and hemo or paraplegia. These are the conditions where succinylcholine is contraindicated. Okay. Next, guys, what can be the reasons of prolonged duration of succinylcholine? So what was the normal duration? 10 minutes. How can this succinylcholine effect be prolonged? One factor is if the pseudocholine esterase is not coming, maybe it is less, or if the pseudocholine esterase is not effective. What are the reasons where it is less in number? Because pseudocholine esterase is produced in the liver, there can be any, if the patient is suffering from any acute liver disease, any severe liver disease, or any sort of acute liver fulminant failure, there can be decrease in pseudocholine esterase, thereby the function, the duration of succinylcholine effect will be prolonged. Okay, conditions like pregnancy has also been found in which pseudocholine esterase is kind of reduced. What are the factors which there is no effect or there is ineffective acetylcholine esterase? One is again liver disease. You know that oral contraceptive pills have a role in liver, like it causes adenomas and stuff like that. So drugs like oral contraceptive pills, pregnancy, old age, burn, and there are two features which I would like to discuss about. One is going to be atypical pseudocholine esterase and phase 2 block. What is phase 2 block, guys, is whenever you give a larger dose, which is more than 5 milligram per kilogram of succinylcholine, maybe couple of days in there, and then a patient can suffer from a decreased effect of acetylcholine esterase. Pseudoacetylcholine esterase. Remember, not acetylcholine esterase, it is going to be pseudoacetylcholine esterase. So what you have to do over there is you just have to give the treatment is going to be mechanical ventilation. Okay, it is going to be mechanical ventilation. Let's talk about something which is known as atypical pseudocholine esterase. If we talk about atypical pseudocholine esterase, there is basically two types. One is going to be homozygous, which is so identical to that of the pseudoacetylcholine esterase, and the other one is going to be heterozygous. The difference in both is in homozygous, the duration prolongs up to 6 to 8 hours, while in case of heterozygous, which is less of a severe case, the prolongation is only around 45 minutes to 60 minutes. Now, how do you differentiate between atypical pseudocholine esterase and that of a normal pseudocholine esterase? You have a local anesthetic drug which we use, that is Debukane number. What does this do is the Debukane usually goes and bind to the normal pseudocholine esterase, because of which you can find out if anyone has atypical pseudocholine esterase, they will not bind, and thereby this is a qualitative analysis. Okay, so what will be the management of if you diagnose a patient with atypical pseudocholine esterase? First is mechanical ventilation, continue your ventilation, and you have to wait until it drowns out. If there is an emergency condition in case of atypical pseudocholine esterase, you can give fresh frozen plasma. Why? Because atypical pseudocholine esterase is transported with the help of plasma. So you give the plasma of a friend. Don't give it of the same family, because as we told you, this is genetically determined. Okay, so I hope you understood the difference between in case of succinylcholine and the depolarizing muscular relaxants. All right. Next, we are going to talk about the pathophysiology of non-depolarizing muscular relaxant. So we already talked about depolarizing muscular relaxant and normal. What happens is the drugs which we use for non-depolarizing muscular relaxant, they go and bind to this 5 receptor, the receptor which will be there of acetylcholine, due to which the acetylcholine cannot be registered in the alpha units, and there won't be any impulse sent. If there is no impulse sent, there will be no depolarization. If there is no depolarization, there won't be any contraction. Thereby, you achieve your goal of muscular relaxation. Now, how do you recover from this phenomena? One thing is that basically there is a competition. That's why this is a competitive inhibition, a competition between our drug and acetylcholine. So one thing is our drug gets metabolized with time, like post-operatively, the drug gets metabolized based on its acting, how long does it act. It gets weaker as compared to the acetylcholine. Now, acetylcholine is usually degenerated by an enzyme which is acetylcholine esterase. So if we give an inhibitor of acetylcholine esterase, there will be prolonged acetylcholine, there will be more acetylcholine, and it will be able to fight and remove this non-depolarizing muscular relaxant so that we'll attain our normal pathophysiology. Correct? So what are those drugs? Drugs like neostigmine, pyridostigmine, and androphonium. These are the normal recovery drugs which we use to recover from the action of non-depolarizing muscular relaxant. So what I told was, in NDMR, it is a competitive inhibition in which our drug goes and binds to the acetylcholine receptor, due to which acetylcholine receptor cannot bind with the receptor. Thereby, there won't be any conduction, there won't be any depolarization, there won't be any contraction. So you achieve the muscular relaxation. And how do you recover from this? By giving drugs like neostigmine, pyridostigmine, or androphonium. Next, we'll talk about the details about with respect to non-depolarizing. Remember guys, it is going to be a competitive blockage as we told. What is the sequence of block? Usually what happens is small muscles get blocked first and then the large muscles. The exception over here is going to be the diaphragm, because there is a huge blood supply. That is why diaphragm gets blocked first, and then will be small muscles, and then will be large muscles. On the other hand, sequence of recovery are usually going to be the larger muscles and then the smaller muscles. But again over here, remember, diaphragm is the one which recovers first, then the large muscles, and then the small muscles. Even though if the diaphragm is recovered, there might be some chances of airway obstruction. Why? Because our upper airway muscles are very sensitive to NDMRs. So that is why always be prepared in case of any airway obstruction type reaction. Okay. If you talk about some details with respect to the drugs which are NDMRs, one will be pancuronium. Why pancuronium is good? Because it is a sympathetic stimulant, due to which it is going to increase your heart rate. It can increase your blood pressure as well. So where will you use this drug? We can use this drug in case of any road traffic accident, in case of any trauma patient, or any hypovolemia patient. Okay. But the side effect of this drug is it is a long acting drug. So the effects are going to be prolonged. Okay. And it is excreted with the help of the kidneys. Excretion is via kidney. Okay. Vancomycin is the most cardiostable drug. That is why we can use this drug in cases of cardiac surgeries or neurosurgeries. Atracurium. Why atracurium is important is because the elimination, normally all the drugs are eliminated with the liver or the kidneys, mostly by the liver. So in conditions, mostly these drugs which are getting eliminated by the liver, we cannot use these drugs in case of any liver failure or any liver disorder, right? And same thing, you can't use the drugs which are eliminated by the kidney in case of a kidney failure. Now in this cases, atracurium and cis-atracurium are very useful because the mode of metabolism is with the help of Hoffman degradation. Basically, what is the meaning of Hoffman degradation is that you don't require any organ, you don't require any enzyme. Both of this, basically Hoffman degradation is a pH, it is a pH and a temperature dependent reaction. So because what happens is normally the temperature at which this cis-atracurium they are working is at 4 degree. Our body temperature is 37 degree. It gets activated and apne aap it will get metabolized. So it does not require. So then what is the benefit over here? You can use cis-atracurium and atracurium in cases of kidney failure or liver failure. So remember, what is the additional side effect of atracurium? In atracurium, remember that you will have histamine release, due to which you will have anaphylactic shock-like symptoms. So what was cis-atracurium? Cis-atracurium is nothing but an isomer of atracurium which does not have this side effect. Now, if you don't have succinylcholine as a if there is any contraindication of succinylcholine, you can use this NDMR which is rocuronium. It is a fast acting which acts by around 30 seconds. It can be used in modified rapid sequence inhibition whenever your succinylcholine is contraindicated. And how does rocuronium get metabolized? Rocuronium is metabolized with a drug which is known as Sugamadex. The combination of rocuronium and Sugamadex is so fast, like the recovery time is very good, that is why it is the agent of choice in daycare surgery. The short acting one which I talked about was mevacronium. The important thing about mevacronium is the metabolism of mevacronium is done by plasma esterases. So since it is shortest acting, it can be used in case of daycare surgery. Remember, if they ask you ultra short, remember that gantacronium. Alright. Next, doctors, we are done with the topic of muscular relaxants. Let us talk about the signs of adequate reversal. When you give neostigmine, when you get pyridostigmine or androphonium, how do you see? Remember, one is regular inspiration and adequate tidal volume. The patient is able to open his eyes, able to move his fingers, able to protrude his tongue, lift the head at least for 5 seconds, able to hold a tongue depressor between the two central incisors. But if they'll ask you what is the guaranteed surest sign is, whenever you do the train of 4, remember we talked about whenever the ratio in the train of 4, the first amplitude and the fourth amplitude, if it is more than 0.9, it is a guaranteed recovery. It is a guaranteed recovery. So this is all about muscular relaxant and signs of adequate reversal. Let us talk about now intravenous inhalational agents. In talking about intravenous agents, you have two types. One is going to be barbiturates and the other one is going to be non-barbiturates. In barbiturates, we have two. One is going to be thiopentan sodium and the other one is going to be methoxytal. In case of non-barbiturates, you have propofol and then based on the derivative, remember imidazoline, etomidate. So OO, so imidazoline and etomidate. Then you will have a phencyclidine derivative, which is going to be ketamine. So we are going to discuss what are the most important things which you cannot miss with respect to these topics. First, we'll talk about the barbiturates. First, you need to know thiopentan sodium. So first of all, you need to know what is the appearance of thiopentan sodium. Thiopentan sodium, guys, is a yellow amorphous powder which has a garlic-like smell. First thing. The onset is within 15 seconds. And the issue with thiopentan sodium is the patient is going to go, like, get anesthetized. He will wake up again, then he get anesthetized again, he wakes up again. This is with a respective duration. I'm just telling you what, it's like a type of lucid interval type, but don't think this is as lucid interval. The patient comes under and then he gets alert again. Hosh wapas aa jata hai. Why this is happening is because of a phenomena which is known as redistribution. Now redistribution means it goes to the vessels and comes back. So basically it goes to the brain. Then after that, where does it go? It goes to the lipids because thiopentan sodium is highly lipophilic. It is a highly lipophilic drug. That is why the patient will be having this on and off phenomena. So it can last up to 12 hours. Next, remember guys, what is the agent? Why it is important for what? First of all, it is an anti-epileptic and it reduces the intracranial pressure. That is why it is preferred in case of any CNS surgery, any brain surgery. Second, as it has anti-thyroid properties. That is why if any patient is suffering from hyperthyroidism, you can give thiopentan sodium. Now, what are the side effects? Now, thing is, usually you give this drug via intravenous. If accidentally you give this intra-arterial, the patient is going to complain with severe pain, pallor, edema, even gangrene. So then this is now what you have to do is, now what your impulse will be, just remove it. No, you don't have to remove it. You have to give normal saline or heparin. Along with that, you have to make sure that at least you're going to block the ganglion which is known as stellate ganglion. Stellate ganglion is a ganglion around the brachial plexus. What it does is it goes and inhibits the sympathetic stimulation, thereby there will be vasodilation. So vasodilation will be there and the effects, the precipitation, basically precipitation occurs within the artery, that is going to get the crystals which are formed that will get dissolved. Okay, so remember this all about thiopentan sodium, the first barbiturate. The second barbiturate, not to know too much about it, just remember methoxytone or hexytal can cause seizures. So it can precipitate seizures, so that's why it is contraindicated in head surgeries. Second thing is that it is used in case of electroconvulsive therapy. And remember, methoxytal is more potent. If they'll ask you, that it is more potent than thiopentan sodium. Okay, but because it causes it can cause seizures, that's why it is not used. Okay, if you talk about the non-barbiturates, in non-barbiturates, the first one which you have to remember is propofol. What you have to remember in propofol, again the same properties. Appearance, propofol is white in color. White color indicates that there is egg lecithin. Now because it is egg, you know that you can't keep egg out for long because it will cause increased risk of microorganisms. So because there is going to be increased risk of microorganism, use it before 6 hours. It has oil, and what oil it has? It has soya bean oil. And whenever you have an oily preparation drug, remember it is going to be painful. So if they will give you a question, which IV inhalational, okay, so you're using an inhalational drug, is IV painful? And the next will be intra-arterial painful. Remember, if it is going to be IV painful, that is going to be your propofol, while intra-arterial is going to be thiopentan sodium. Okay, so please make sure that you're not making the difference between IV. Whenever it is you're going IV, the pain is going to be because of propofol, and accidental intra-arterial is going to be thiopentan sodium. Next, if you see what are the uses, what are the dosage which you use, dosage is going to be around 1 to 2 milligram per kilogram. The best thing about propofol is it is rapid recovery, so that's why it can be used in daycare. It has anti-pruritic property, so that's why it is beneficial. And if you think that operation can be too much nauseating post, so that's why it is also an anti-emetic. So three things: anti-emetic, anti-pruritic, and a quick recovery will be there. So if they'll ask you what are the agent of choice, remember it is going to be daycare, it is going to be endoscopic and colonoscopy. Why? Because these are monitored anesthetic procedures or short acting procedures. So that is why you will be using propofol. Then you'll have sedation in ICU. But remember, you will not use sedation in ICU for long because you have a syndrome which is known as propofol infusion syndrome. Propofol infusion syndrome is includes refractive bradycardia, metabolic acidosis, and even arrest. Why? If you use large and prolonged amount of propofol, along with that, the urine will be green in color. So make sure you know all these factors of propofol. Next, we will be talking about etomidate. So with etomidate, I can remember the side effects within its name itself. E for it is emetic in nature. M, it causes myoclonic seizures, which means the patient will have jerky movements during the operation also. And then along with that, A will be having adrenal suppression. So adrenal suppression will be causing prolonged effect of it, the sedative effect. So if you talk about etomidate, if they'll ask you what is the effect, remember the color. It is going to, sorry, the appearance. It is going to be oily in nature. And what I told you, whenever it is oily, via IV, it is going to hurt. Then the property, the best property is going to be it is cardio stable. So it is cardio stable, due to which any condition related to the cardiac surgery, or if you're doing cardio version, obviously if a patient is having a narrow QRS, which is a paroxysmal supraventricular tachycardia, and the patient is unstable, you have to give a DC shock. Now that DC shock mein maza to nahi aayega, it will be very painful. So before that, you can give etomidate. Alright. Along with that, any aneurysmal surgery of the brain. Now normally if you have a surgery of the brain, you're going to give thiopenton sodium. But if they'll have aneurysmal surgery, you are going to prefer etomidate. What are the side effects which we already taught? E for emetic, M for myoclonic seizures, and A will be adrenal suppression. This much you need to know about etomidate. Then we will be talking about the last one, which is ketamine, a very important drug. Remember guys, if they'll this thing, all intravenous agents are depressants, okay, except ketamine. Okay, first except, and then again, all intravenous agents act on GABA receptor except ketamine, because ketamine acts on NMDA receptors. It acts on NMDA receptors, that's why it is also a stimulant. Okay, so remember these two things. Okay, all IV agents are depressant except ketamine, it is a stimulant, and all IV inhalation, all IV anesthetics, they are going to act on the GABA receptor except for ketamine, which is going to act on the NMDA receptor. So first thing first, remember the thing which you see in case of ketamine is dissociative anesthesia. What is dissociative anesthesia? Is the patient is awake but he will not feel any pain. That is dissociative anesthesia. It is the dissociation between the thalamus and the cortex. Okay, it is a dissociation between the thalamus and the cortex. So what are the side effects of ketamine? First, you will have unpleasant hallucinations. Remember guys, in propofol, the common cause of addiction of propofol is you have pleasant, P for propofol, P for pleasant hallucinations. Okay, while if they will ask you where do you see unpleasant hallucinations, you have ketamine. Still it is unpleasant, people do get addicted. So to prevent this addiction, we are going to give a drug which is midazolam. Now ketamine causes increase in oral secretions. So what you have to give oral secretion now because of cholinergic effect. So give some anticholinergics. Anticholinergics like atropine or glycopyrrolate can be given to reduce the oral secretions. If they'll ask you what are the uses, if you talk about the uses with respect to the order, see this. First will be your heart. In case of any shock, now what ketamine is a stimulant, so it is going to increase the heart. If you will talk about it, we'll talk about it order wise, you'll remember. In case of CNS, it is contraindicated in CNS surgeries and in case of eye surgeries. Why? Because it causes increase in the intracranial pressure and intraocular pressure. It causes increase in intraocular pressure. So thereby it is contraindicated in CNS and eyes. If you talk about the cardiovascular system, in case of any road traffic accident, in case of any hypovolemic situations, you will give ketamine, but you will not give it in any conditions like patient is suffering from hypertension or previous MI. Why? Because ketamine causes increase in heart rate and increase in blood pressure. If we talk about the respiratory rate, it is good in case of respiratory system, it causes bronchodilation. So that is why in case of asthmatic patients, it is a good choice. Along with that, ketamine, it can be done in case of when you have scarcity of sources. Ketamine can be the only sole agent which you can use for anesthetic purpose. It can be used for the treatment of chronic pain in cases of incision and drainage type treatment. So basically all short duration procedures, ketamine can be used. Remember what are the contraindication? Neurosurgery, ocular surgery, and if anyone has hypertension or MI. So this is all with respect to the IV agents as well. In the next topic, we will be talking about local anesthetics and the inhalational agents. So there are two scores, guys. Let's bring our integration again. One is one Z score and one T score, which determines what is this condition. Now tell me, Z score and T score are used in what condition? Comment below. Okay, thank you so much. We're done with this video. I hope you understood this. It was a quick video, but everything and each and every line discussed in this video is very, very important PYQ. Thank you guys. See you guys in the next video. Bye-bye.